Hi, Assalamualaikum warahmatullahi wabarakatuh to Miss Faika and to all my friends. My name is Amalia Binti Sanusi. I am going to present to all of you about my topic, which is hip radiography image evaluation. Okay, first of all, I will explain to you about epi-hip. Okay, first, we need to detect whether our image is epi-hip or epiproximal femur or epipelvis. Okay, to know that our image is epi-hip, here only one half of the sacrum, coccyx, and the symphysis pubis are included within the exposure field. And this is epiproximal femur. And why not epi-hip? Because proximal femoral shaft, hip, and surrounding femoral soft tissue are included within the exposure field. And why I say this is epipelvis and not epihip? Because entire pelvis and proximal femora included. Okay, next. Okay, based on the placement, first P projection. Okay, this is a radiograph of epi projection of the hip. I say so because proximal 1/3 of femur included, hip joint space and acetabulum visualized, lesser trochanter not visible or only slightly visible. Okay, next, P, positioning. Okay, this is the positioning criteria for true epi-hip. Okay, first point, ischial spine is aligned with pelvic rim. Sacrum, coccyx are aligned with the symphysis pubis. Obturator foramen is open. Femoral neck is demonstrated without foreshortening. Greater trochanter is in profile laterally, and the lesser trochanter is superimposed by the femoral neck. Okay, these three criteria that I have been bold with red color are referred to the patient's leg is internally rotated until the foot is angled 15 to 20 degree. Okay, next. Okay, this is the simplest wrong positioning for epi-hip. Okay, first, this image foot is referred to the leg externally rotated to position the foot at 45-degree angle with the table. This is because femoral neck foreshortened, femoral neck demonstrated on end, and the lesser trochanter is demonstrated in profile. To improve this, internally rotated the leg until the foot is angled 15 to 20 degrees from vertical and the femoral epicondyles are positioned parallel with table. Okay, next. This image shown patient rotated toward affected hip. This is because ischial spine is demonstrated without pelvic brim superimposed. Sacrum and coccyx are not aligned with symphysis pubis but are rotated away from affected hip. And the obturator foramen is narrowed. Okay, to improve this, rotate the patient away from affected hip until axes are positioned at equal distance from the IR. Okay, last. Okay, this image shown that the patient rotated away from affected hip. This is because ischial spine is not aligned with the pelvic brim but is demonstrated closer to the acetabulum. Sacrum and coccyx are not aligned with the symphysis pubis but are rotated toward affected hip. And the obturator foramen is widened. To improve this, rotate the patient toward affected hip until the axes are positioned at equal distance from the IR. Okay, next. Okay, this is the comparison with between true epi-hip position with wrong position of epi-hip. Okay, first I will start with wrong position. Okay, this is epi-hip leg externally rotated. Okay, with the patient's leg externally rotated, the greater trochanter, especially superimposed over the femoral neck. Okay, to improve this, internally rotate the leg until the foot is angled 15 to 20 degrees from vertical. This is also wrong positioning for epihip with the leg internally over rotated. Okay, this is leg internally over rotated. Okay, with internal rotation of the patient's leg can be overdone. The patient's leg have been internally rotated to a degree that the patient's lateral trochanter is not demonstrated. Okay, it to improve this, externally rotate the leg until the foot is angled 15 to 20 degrees from vertical. Okay, this is the true epihip position. Okay, with the patient's leg internally rotated, there is maximum visualization of the femoral neck. Okay, next. Okay, this is based on my radiograph. Okay, the positioning for this projection is incorrect. This is because femoral neck, especially foreshortened, lateral trochanter is demonstrated on profile medially, and the leg was externally rotated, bringing the foot vertical and the femoral epicondyles to an approximately 15 to 20 degree angle with the table. Okay, to improve this, internally rotate the leg until the foot is angled 15 to 20 degrees from vertical and the femoral epicondyles are positioned parallel with the table. Okay, next. For alignment A, okay, the alignment between X-ray tube and cassette cannot be determined because there is no evidence of collimation on all four borders of the film. The alignment between X-ray tube and patient cannot be determined too because there is no evidence of collimation on all four borders of the film. The alignment between a patient and cassette is incorrect because the distance between the central structure to the edge of film on a left and a right is not equal. The centering point for this radiograph cannot be determined because do not have four borders of collimation. The standard centering point for this projection should be at the femoral neck. Okay, next. For collimation. At the superior border, structures that should be included are ASIS, anterior superior iliac spine, iliac crest, and ilium. While at the inferior border, structures that should be included are femur, ischial tuberosity, obturator foramen, and a lateral trochanter. At the lateral border, structures that should be included are ASIS, anterior superior iliac spine, greater trochanter, and femur. Okay, based on this radiograph, there is no any radiation protection apparatus seen on the radiograph. Okay, next, for exposure factor, the KVP used is over-penetrate for penetration and radiographic contrast. This is because the bony cortical outline of thin structure, which is greater trochanter, cannot be seen, and the bony cortical outline of thick structure, which is a femoral head, can be seen. The KVP must be decreased by 15%. Okay, for the MAS, the MAS use is overexposed for detail and density. This is because the bony trabecular pattern of thin structure, which is greater trochanter, cannot be seen, and the bony trabecular pattern of thick structure, which is femoral head, can be seen. So the MAS must be decreased opacity by 2 times. Okay, next. Markers. There is no evidence of plumbar marker shown on the radiograph, but the marker is in correct position. To improve this, use plumbar marker and press appropriately and superimpose with a region of interest. Okay, next, for aesthetic. Okay, the size of film used for this radiograph cannot be determined. The size of film which is sufficient for this radiograph is 24 times 30 cm. It is the appropriate size to demonstrate all structures of the interest. There is evidence of internal artifact on the radiograph, which is white patches on the radiographic film. Okay, next, for name, the patient's name and ID date of examination are not visualized on the radiograph at the appropriate area. The patient's name should be at above or below of the edges of film and superimposed with structure of interest. Okay, for conclusion, the radiograph is not acceptable because there is no patient's name, ID, date, and place of examination, and there is no plumber marker. Okay, next, we proceed with lateral hip. Okay, I will explain to you about lateral hip. Okay, first, we need to detect whether our image is a lateral hip or a lateral pelvis or lateral proximal femur. Okay, first, to compare between a lateral hip and with a lateral pelvis, in the lateral hip, proximal femur, hip joint, and acetabulum should be visualized, while lateral pelvis, image should be include acetabula, femoral head, and neck. Then, to compare between lateral hip with the lateral proximal femur, lateral hip, femoral neck is superimposed over the greater trochanter, while lateral proximal femur, femoral neck, and head are superimposed over the greater trochanter. Okay, so we know that our image is lateral hip. Okay, next, projection. Okay, this is a radiograph of lateral projection of the hip. I say so because femoral head and neck in profile, the bony pelvis is imaged from axis to the proximal shaft of the femur. Lateral trochanter is demonstrated in profile. Proximal one-third of femur is visible. Anti-femoral head, neck, and trochanters, which are greater trochanter and a lesser trochanter, center to IR. Okay, next, positioning. Okay, this is the positioning criteria for true lateral hip. Okay, first point, ischial spine is aligned with pelvic rim. Sacrum and coccyx are aligned with symphysis pubis. Obturator foramen is open. Lesser trochanter is in profile medially. These four criteria that I have been bold with green color refer to the patient that flex knee and hip until the femur is angled at 60 to 70 degrees with the table. Okay, next, femoral neck is superimposed over the greater trochanter. Femoral neck is specially foreshortened. Okay, these two criteria that I have been bold with red color refer to the patient that abduct the femoral shaft to 45-degree angle with the table. Okay, next. Okay, this is the sample wrong positioning for lateral hip. Why I say this wrong positioning? Patient rotated away from affected hip and the knee and hip flex less than needed or not enough to position the femur at 60 to 70 degree angle with the table. So its results, the greater trochanter is demonstrated laterally. To improve this, rotate the patient to affected hip until axes are positioned at equal distance from the IR. Then increase the degree of knee and hip flexion until the femur is positioned at 60 to 70 degree angle with the IR. Okay, next, why I say this image wrong positioning too. Knee and hip flex more than needed or too much to position the femur at 60 to 70 degree angle with the table. So it results the greater trochanter here we can see is demonstrated medially. To improve this, decrease the degree of knee and hip flexion until the femur is positioned at 60 60 to 70 degree angle with the IR. Okay, next. Okay, this is based on my radiograph. The positioning for this projection is incorrect. The ischial spine, this is because ischial spine is demonstrated without pelvic beam superimposition. The obturator foramen is narrow. The greater trochanter is partially demonstrated laterally, indicating that the leg was flexed less than needed, which is 60 to 70 degrees from the IR. Okay, to improve this, rotate the patient away from affected hip until assist are positioned at equal distance from the IR, and increase the degree of knee and hip flexion until femur is positioned at 60 to 70 degree angle with the IR. Okay, next. Alignment. The alignment between X-ray tube and cassette cannot be determined because there is no evidence of collimation on all four borders of the film. The alignment between X-ray tube and patient cannot be determined too because there is no evidence of collimation on all four borders of the film. The alignment between a patient and cassette is incorrect because the distance between the central structure to the edge of film on the left and right is not equal. The centering point for this radiograph cannot be determined because do not have four borders of collimation. The standard centering point for this projection should be at the mid-femoral neck here or hip. Okay, next. For collimation. Okay, at the superior border, structures that should be included are ASIS, anterior superior iliac spine, iliac crest, and ilium. While at the inferior border, structures that should be included are femur, obturator foramen, ischial tuberosity, and a lesser trochanter. At the lateral border, structures that should be included are ASIS, anterior superior iliac spine, greater trochanter, and femur. Okay, there is no any radiation apparatus seen on the radiograph. Okay, next. For exposure factor, the KVP used is adequate for penetration and radiographic contrast. This is because the bony cortical outline of thin structure, which is a lesser trochanter, can be seen, and the bony cortical outline of thick structure, which is femoral head, can be seen. So there is no change needed. Okay, for the MAS, the MAS use is adequate for density and detail. This is because the bony trabecular pattern of thin structure, which is a lesser trochanter, can be seen, and the bony trabecular pattern of thick structure, which is femoral head, can be seen too. So there is no change needed. Okay, next. Markers. Okay, for markers, there is no evidence of plumbar marker shown on the radiograph, but the marker is in correct position. To improve this, use plumbar marker and place appropriately and superimpose with a region of interest. Okay, next. For aesthetic, the size of film used for this radiograph cannot be determined. The size of film which is sufficient for this radiograph is 24 times 30 cm. It is the appropriate size to demonstrate all structures of the interest. There is no any artifact seen on the radiograph. Okay, next. For name. The patient's name and ID date of examination are not visualized on the radiograph at the appropriate area. The patient's name should be at above or below of the edges of film and not superimposed with structure of interest. Okay, next. Okay, for conclusion, the radiograph is not acceptable because there is no patient's name, ID, date, and place of examination, and there is no plumbar marker. Okay, last. Okay, this is all references that have been used. presentation. Okay, you can refer from these references if you want to know more about hip radiograph. Okay, that's all from me. Thank you.